Okay.
Just give me 5 minutes.
Yes.
Yes, sir. Yes, sir. How are you, sir?
Fine, very fine. Thank you for inviting me.
Thanks for accepting our invitation. I think early morning for you.
Yes. Can I try to share my presentation if the
Ah.
slides?
Yeah, sure, sir. Please do try.
Okay. Okay, the slides.
Yes, sir. We can see. Absolutely perfect.
See? Can I try to go up? Okay.
Yes, we can see perfect, sir.
Okay. The technical issue are served with this kind of presentation. So. Okay.
I shall be producing this, of course. I'm sure that
Okay.
I'll check this. You are going to share this. You have to answer your slides. You have to stop sharing. Sir, you have to stop sharing this because I'm going to show the slide. Sir, are you able to hear me? Yeah, are you able to hear me, sir? Are you able to hear me, sir? able to hear us?
He is not connected to audio.
Now,
Now he is connected.
now. Yes.
Okay,
Are you
now.
able to- Yeah, we can hear you, sir. Are you able to hear us?
Now, okay.
Dr. Surana can go now.
Yeah, I will share this. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Michael Morley from Milan, Italy, and he's going to lecture us on management of vaccinations in NHL patients. This webinar is brought to you by Mumbai Hematology Group, supported by Pfizer and Lucent Life Sciences, and managed by Perfect Square. I thank Team Pfizer and Team Lucent for supporting this present webinar. Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Michael Morley from Milan, Italy. All our discussants were themselves very eminent hematologists as well as medical oncologists, and you participants for sparing your Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 23rd of June 2024, from 11:30 a.m. Indian Standard Time and 8 a.m. Swiss time, we have Dr. Marco Capecci from Pisa speaking to us on frontiers in ITP treatment. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Professor Dr. A.K. Tripathi from Director Dr. RML Institute of Medical Sciences, Lucknow, as well as Director Sanjay Gandhi PG Institute of Medical Sciences, Lucknow. Dr. Abha Dubey from Arvita Super Specialty Clinic, Ahmedabad. Dr. Abhilasha S. from JNMC, Belgavi, Karnataka. Dr. Anil Singhvi from CHL Hospital, Indore. Dr. Aruna Pujari from Bridge Candy Hospital Trust, Mumbai. Dr. Ashutosh Panigrahi from AIMS, Bhubaneswar. Dr. Ashwini K. Sood from IG Medical College, Shimla. Dr. Aisha Sunawala from PD Hinduja Hospital and Medical Research Center, Mahim, Mumbai. Dr. Bhavin Shah from Hemato-Oncology Clinic, Vedant, Ahmedabad. Dr. Dharani Jayaram from Chennai. Dr. Divya Manohar from Madras Medical College, Chennai. Professor Dr. Ghanshyam Biswas from Odisha Society of Oncology, Bhubaneswar. Dr. Gopinathan M. from MGM Healthcare, Chennai. Dr. Kirti Sabnish from Mulund, Mumbai, Fortis Hospitals. Dr. Mohammad Mir Hussain from BMT and Medical Oncology Unit, SKIMS, Srinagar. Dr. Nadim Shoket from American Oncology Institute, Jammu and Kashmir. Dr. Prabodha Kumar Das from AIMS, Bhubaneswar. Dr. Priyadarshini Preram from AIMS, Bhubaneswar. Dr. Priyanka Samal from IMSN Some Hospital, Bhubaneswar. Dr. R. Prasanna from Cancure Cancer Center, Tiruchirappalli, Tamil Nadu. Dr. Rupam Deka from AIMS, Guwahati. Dr. Saroj Panda from Some Hospital, Bhubaneswar, Odisha. Dr. Satrupa Mahapatra from Bakchi Sri Shankara Cancer Center and Research Institute, Bhubaneswar. Dr. Sri Gopal Mohanty from SCG Cancer Center, Cuttack. Dr. Tanu Singhal from KD Ambani Hospital, Andheri, Mumbai. Dr. Thilagavati Venkateshan from VS Hematology Oncology and BMT Center, Chennai. Dr. Tushar Pandey from IMSN Some Hospital, Bhubaneswar. Dr. Umang Agrawal from PD Hinduja Hospital and MRC, Mumbai. Now it's a time to introduce our guest speaker for the day. We have with us Dr. Michael Morley from Milan, Italy. Dr. Michael Morley is Clinical Assistant, Head, Indolent Lymphoma Unit, Division of Hematology, the Fondazione IRCCS CA Granda, Ospedale Maggiore Policlinico, Milan, Italy. His university education include: he graduated in medicine and surgery from University of Pavia, Italy in the year 2005. He received his postgraduate diploma in hematology from the University of Pavia, Italy in the year 2009. He is also the clinical assistant at the Division of Hematology of the Fondazione IRCCS Policlinico San Matteo in Pavia, Italy from the year 2009 to 2010. Also the clinical assistant at the Division of Hematology at University Hospital, Ospedale di Circolo e Fondazione Maci in Venice, Italy. He served as head of the outpatient oncohematology service from the year 2011 to 2023. He was appointed as Vice Director, Division of Hematology since October 2019. Since October 2023 to date, he held the position of Clinical Assistant as a Division of Hematology of the Fondazione IRCCS CA Branda Ospedale Maggiore Policlinico in Milan, Italy, as head of the indolent lymphomas unit. His main areas of scientific activity include the diagnostic, prognostic, and therapeutic aspects of non-Hodgkin lymphomas. In particular, he also participated in the development and validation of new prognostic models in NHL, such as FLIPI2 in follicular lymphomas in BJH2010, hepatitis C prognostic score in HCV-positive diffuse large B-cell lymphomas, published in Hematologica 2014, POD24 in margin zone lymphomas, published in Blood 2019, and MZL IPA score, published in ICML 2023. He is also cordially invited, as well as has conducted many studies on relationship between chronic hepatitis C virus infection and indolent lymphomas and DLBCL, with a special focus on the impact of the new direct-acting anti-HCV antiviral drugs in patients with HCV-positive DLBCL. In 2022, he published on behalf of the Fondazione Italiana Linfomi, that is FIL, the results of the first prospective study on the use of DAAs, that is direct-acting anti-HCV antivirals, as first-line curative therapy in patients with HCV-positive indolent lymphomas, which has been published in BART study JCO 2022. He also participated in pivotal phase 2 and phase 3 clinical trials of new targeted chemo-free drugs for the personalized treatment of B-cell lymphoid neoplasm, such as PI3 kinase inhibitors like duvelisib, BTK inhibitors like ibrutinib, zanubrutinib, and pertobrutinib, and anti-CD20, CD3 bispecific antibodies, namely epcoritamab, mosunetuzumab, and odronextamab. Finally, he is the coordinating principal investigator in a prospective nationwide study of the FIL evaluating prospectively the activity and persistence of COVID-19, VZV, and childhood vaccines in patients with follicular lymphoma undergoing immunochemotherapy and anti-CD20 maintenance. He also coordinated a multidisciplinary group of hematologists, immunologists, and infectious disease specialists on behalf of the FIL Long Survival, Comorbidities, and Quality of Life Committee in a project evaluating the activity of vaccines in patients with lymphoma, which has been published in the British Journal of Hematology. He is a founding member of Fondazione Italiana Linfomi, that is FIL, and is a member of the board of Indolent Lymphoma Committee. In 2024, he was appointed representative of the FIL in the International Extranodal Lymphoma Research Group, that is IELSG. He is the author of 100 research articles in index journals, including the Journal of Clinical Oncology, Blood, Hematologica, Annals of Oncology, Blood Advances, Clinical Research, Clinical Cancer Research, American Journal of Hematology, The Oncologist, British Journal of Hematology. And today he's with us and is going to lecture us on management of vaccinations in NHL patients. Well, thank you so much. I stop over here. Over to you, sir, for your lecture.
Thank you very much for this very kind introduction. I'm honored to speak with you about this topic, management of vaccination in patients with non-Hodgkin lymphomas. I start my presentation.
So full screen mode, please, sir. Yeah.
Okay.
Not yet,
It's
sir.
okay?
Yes, perfect, sir. Please go ahead.
Okay. So this is the paper we published this year in the British Journal of Hematology on behalf of the Long-Term Survivors, Morbidity, and Quality of Life Committee of the Fondazione Italiana Linfomi. Vaccination is one of the most valuable tools in preventing infectious disease in the general population. The immunocompromised host is at increased risk of developing complications from vaccine-preventable disease, including SARS-CoV-2. Immune responses to vaccines may be impaired in immunosuppressive subjects due to chronic disease or therapies that blunt the immune system, such as chemotherapy, immunotherapy, and targeted agents. Data on the effectiveness of vaccination in patients affected by B-cell non-Hodgkin lymphomas, however, are limited and highly heterogeneous. A moderate to strong reduction of the extent of vaccine-induced immune responses have been observed in patients affected by B-cell non-Hodgkin lymphomas. Current guidelines such as IDSA, HL7, and the ASCO guidelines that has been published this year still recommend common vaccination with the exclusion of live attenuated products due to safety concerns rather than efficacy concerns. B-cell non-Hodgkin lymphoma patients may present functionally defective response to vaccines, and further impairment is rely on the effect of the anti-CD20 monoclonal antibodies such as rituximab or obinutuzumab. After rituximab administration, sustained B-cell depletion occurs within 72 hours, while the recovery of the cell counts usually starts only 6 to 9 months after the completion of therapy, with normal levels being reached only after 9 to 12 months. This is one of the most seminal study published in 2002 in B-cell non-Hodgkin lymphoma patients, showing that humoral responses against tetanus and poliovirus vaccines that are recall antigens decreased after rituximab treatment. This is one of the most recent meta-analysis evaluating vaccine response following anti-CD20 monoclonal antibody therapy. And this review and meta-analysis on more than 900 of patients, including 38 studies and 19 evaluating patients with hematological malignancies, showed that seroconversion rate of patients on active anti-CD20 therapy is very low, very negligible, about 0%. Seroconversion rates improve, however, as time passes, 6 to 12 months from last dose, but are still reduced to 12 months after treatment. Overall, vaccination appears safe in patients receiving anti-CD20 therapy. The COVID-19 pandemic made clinicians aware of the crucial importance of preventing life-threatening complications of SARS-CoV-2 and the importance of vaccination in this setting of patients. And we learned many lessons during COVID-19 pandemic. One is that vaccination with mRNA vaccines that are the most effective in patients with non-Hodgkin lymphoma receiving B-cell depleting therapy induce limited seroconversion rates. Also, the time interval between anti-CD20 therapy and vaccination is critical on the probability of generating neutralizing anti-spike antibodies. And finally, cellular responses after COVID-19 vaccines have been detected in majority of patients, also if treated with anti-CD20 monoclonal antibodies, independently from humoral responses. So this is the outline of my presentation. I will discuss COVID-19 vaccines, seasonal influenza virus, varicella zoster virus, encapsulated bacteria, diphtheria, tetanus, pertussis, and poliovirus vaccines, hepatitis B and hepatitis A virus, and respiratory syncytial virus, RSV. So starting from COVID-19, as you know, during the early pandemic, the risk of hospitalization and death after COVID-19 infection among NHL patients was very high. These are the data from the ITA-HEMA-CoV field study that was the first study reporting the outcome of hematological patients who contracted COVID-19 during first and second wave. So in the period there were no vaccines. The 100-day mortality was about 20% in indolent lymphoma patients and about 30% in large B-cell lymphoma patients, while mortality was lower in Hodgkin lymphoma patients. This study, published by Carlo Visco in Italy, collecting data from Italian patients during the first and second wave of COVID-19 spread, showed that 4 independent risk factors for mortality that were age over 70 years, male gender, low platelet counts, and low absolute lymphocyte counts. Combining these factors, we developed a risk model predicting mortality after COVID-19 infection. So this is the life cycle of SARS-CoV-2 that bind to ACE2 receptor with receptor binding domain RBD of the spike protein. The virus is internalized and then replicates and escape from the cell, infecting other cells. This mechanism of entry was exploited in the discovery of effective vaccines. There are different types of vaccines. The most effective were messenger RNA based, the Pfizer product and the Moderna product. There were also other types of vaccines, the spike adenovirus based DNA, the Oxford product and the Janssen product, and other different type of vaccines, the adjuvanted recombinant spike proteins such as Novavax. During the evolving of the pandemic, mRNA-based vaccines shortly became the standard at the global level and were approved also as booster doses in late 2022. The effectiveness of primary vaccination declined over time due to waning immunity and the emergence of variants of concerns, carrying neutralization, escape mutations in RBD sequence, in particular in the Omicron subtypes. In the third quarter of 2022, two bivalent vaccines containing equal amounts of spike mRNA from the ancestral 1 strain and Omicron BA.4, BA.5 subvariant were approved as new boosters. And now updated mRNA vaccines against currently dominant variants such as XBB 1.5 have been recently approved by FDA, the so-called 2023-2024 formula that demonstrated protection also against the JN.1 and other circulating variants that are currently ongoing. So this is one of the first studies coming from Israel evaluating humoral responses after COVID vaccine in NHL patients. So patients with distal non-Hodgkin lymphoma currently treated with an anti-CD20 monoclonal antibody containing therapy were unlikely to achieve humoral responses to the Pfizer mRNA COVID-19 vaccine. So you can see that patients on under active anti-CD20 therapy develop negligible level of antibody protection compared to patients immunized after the completion of treatment and treatment-naive patients and healthy controls. With a longer time from past exposure to anti-CD20 monoclonal antibodies, the rate of patients with detectable protective antibodies rised with a higher rise in patients with aggressive non-Hodgkin lymphoma versus patients with indolent non-Hodgkin lymphoma. This is one of the first published meta-analysis published by Nico Gagelman in Hematologica, evaluating antibody response to COVID-19 full vaccination with mRNA vaccines. Overall, the seroconversion rate was 58% in aggressive non-Hodgkin lymphomas and 61% in indolent lymphoma, compared to 98% in healthy control. Importantly, patients treated with anti-CD20 monoclonal antibody within 1 year showed 15% of response to vaccination compared to 59% of patients treated more than 1 year before. Also, patients with Bruton tyrosine kinase inhibitors showed very low rate of immune responses, 23%, while patients in remission show higher rate of responses compared to patients with stable or progressive disease. Finally, patients with prior COVID-19 exhibited higher rates of immune protection after vaccine. This is an important study published in JCO, confirming that binding and neutralizing antibody titers were significantly reduced in patients with non-Hodgkin lymphoma or chronic lymphocytic leukemia compared to controls, particularly those receiving anti-CD20 monoclonal antibody within 1 year from vaccination. Importantly, the study showed that infection with Delta and Omicron variants, that antibodies against the infection Delta Omicron variants were impaired in neutralizing activity. So the emergence of Omicron and variants raised the need for more effective vaccine strategies. So a booster doses, third and fourth booster doses with mRNA vaccines were introduced, especially in immunocompromised patients, such as patients with hematological malignancies. This is one of the first studies evaluating a third mRNA vaccine dose. The minority of patients remains seronegative. A great number of patients seroconverting from seronegative to seropositive, and the majority of patients increased the anti-spike antibody levels, so the so-called sero-elevated cohort, while a minor number of patients decreased the level of antibody. Patients under BTK inhibitors increased their antibody levels, while patients under active anti-CD20 monoclonal antibody did not respond to the third dose. This is another study from England showing that in B-cell non-Hodgkin lymphoma patient, the fourth dose, the second booster dose, increased seroconversion and neutralization titers against wild type and Omicron variant from about 50% to 90%. After the introduction of vaccines, the number of recruit COVID-19 infection decreased, but especially mortality decreased. These are the data, the observational data from EPIC-COVID EHA study, collecting data from Europe in patients who received 2 to 3 doses of vaccines, and 70% were infected by Omicron variants. So in this early series, mortality decreased from the original 20% in indolent lymphoma to 90.7%, and in patients affected by large B-cell lymphoma from original 30% in the pre-vaccine era to 9.3%. The majority of patients who developed a severe infection leading to death did not respond to the immunization with vaccines, mainly due to recent immunochemotherapy, as shown in this picture. So patients with B-cell non-Hodgkin lymphoma remain particularly susceptible to breakthrough infection and severe COVID-19 infection, especially if treated with anti-CD20 monoclonal antibodies. The UK Prosecco study was a very important study evaluating prospectively patients with non-Hodgkin lymphoma undergoing COVID-19 vaccination. The authors were able to detect and validate 2 thresholds of serum anti-spike antibodies, predicting in a multivariable analysis protection from breakthrough infection after third or fourth doses of vaccines. In particular, the threshold after the third dose was equal to 820 units, and the threshold after fourth dose was 41 units. So the decrease of the threshold after fourth dose is depended by the antibody affinity maturation with repeated vaccination. So this threshold could be taken into account when evaluating protection from COVID-19 in patients undergoing the initiation of chemoimmunotherapy, for instance. Another important concept was that pre-established humoral immunity by vaccine seemed to be spared in patients undergoing anti-CD20 monoclonal antibody. This is based on very few data. However, it was the basis for guidelines. So patients with vaccination before the start of anti-CD20 monoclonal antibody containing treatment maintained the time after 4 months the antibody blocking COVID-19, while on the contrary, as we know before, we saw before, patient vaccine after anti-CD20 containing treatment did not develop any humoral immunity protection. Moreover, the study demonstrated that anti-spike levels naturally reduced over time, highlighting the importance of booster doses. Also, the Prosecco study confirmed the relevance of booster doses, as 70% of patients with indolent lymphoma improved antibody response following booster vaccination. Moreover, the studies showed that antigen-specific T-cell responses increased after third doses, irrespective of the cancer treatment status. So cellular immunity increased also with booster doses, irrespective of any treatments, also anti-CD20 monoclonal antibody treatment. This was demonstrated in many studies. These are 2 Italian studies showing that cellular immunity seemed to be substantially preserved in patients with B-cell non-Hodgkin lymphoma even after anti-CD20 treatment, as measured by assays evaluating interferon gamma secretion after stimulation with SARS-CoV-2 peptides. These are ELISpot assays. And this cellular immunity is protection was and development was independent from humoral response status. There were few data about the persistence of cellular immunity in patients undergoing anti-CD20 based treatment. This is a Spanish study. In this, the right panel, can see that patient with lymphoma, in patients with lymphoma, cellular immunity remains stable and also increased after repeated vaccination dose, even during anti-CD20 chemoimmunotherapy treatment. So cellular immunity did not decrease, in contrast to humoral immunity that did not develop or decrease after anti-CD20 monoclonal antibody. So these data were the basis for the recommendation about COVID-19 vaccines in patients with non-Hodgkin lymphomas. The recommendation was to ensure a 3 doses cycle in patients with less than 5 total prior doses undergoing active treatment should be immunized with 1 additional dose of the updated mRNA vaccine at least 4 to 8 weeks apart from last doses. This supportive data for this recommendation are very strong. There are a lot of data, and the best timing in relation to anti-CD20 treatment is at least 2 weeks before the anti-CD20 treatment start, or at least 6 to 12 months from the last administration of an anti-CD20 monoclonal antibody. In patients on chronic anti-CD20 treatment, such as indolent lymphoma patient in maintenance treatment, the recommendation is to ensure at least 4 weeks before the next scheduled anti-CD20 administration. So these are the details of the recommendation we published in the paper. We also consider the threshold from Prosecco study to evaluate the status of the patient against COVID-19 virus. And these are the current CDC recommendation with details of on the products that should be administered in patients unvaccinated or vaccinated with different number of doses and different prior types of vaccines. During the pandemic, also other kind of immune protection were adopted. This is the phase 3 trial evaluating pre-exposure prophylaxis with tixagevimab, silgavimab. That was a long-term intramuscular cocktail of monoclonal antibody that showed reduction of risk of symptomatic infection. This treatment was pre-exposure prophylaxis was adopted in many countries, and there are many reports of use of this prevention treatment in patients with hematological cancer. This is a study from our center. We evaluated more than 200 patients eligible to tixagevimab. 130 received effectively the antibody, while 74 did not due to refusal or logistical issue. This is the control group, and you can see that patient with treated with tixagevimab and silgavimab experienced less infection and also less hospitalization and or severe or fatal infection. So we concluded that this prophylactic treatment may reduce the incidence and severity of COVID-19 and may be a complementary to vaccination booster in patients with hematological malignancies. Unfortunately, although this treatment was approved by FDA and EMA, based on preliminary and encouraging results, in January 2023, the FDA retired the authorization due to the spread of Omicron subvariants such as BQ.1.1 and XBB 1.5 that have been demonstrated to be substantially unsensitive to tixagevimab, silgavimab. However, this proof of concept treatment demonstrated to be effective, and there are currently other new monoclonal antibody potentially active against both historical and current COVID variants that are currently being tested in clinical trials. So now I will talk about seasonal influenza virus. This is one of the most common infectious diseases worldwide, impacting on all age group and affecting morbidity and mortality. The most effective method for preventing influenza is the annual vaccination. Patients with non-Hodgkin lymphoma are at particular risk of influenza virus infection and complication because of constitutive immunodeficiency and especially immunosuppressive therapies and frequent advanced age. All major clinical society guidelines recommend seasonal influenza shots for cancer patients, including hematological malignancies. However, data on the immunogenicity of influenza vaccination in non-Hodgkin lymphoma patients are not homogeneous, possibly due to the antigenic variability of seasonal influenza strains, different patient characteristics, disease features, and treatment regimens. There were contrasting results in seroconversion after flu vaccine in non-Hodgkin lymphoma patients. Similar study in pre-rituximab era yielded contrasting results. Increasing the number of doses 2 versus 1 does not seem to impact the seroconversion rate. In contrast, the amount of vaccine products seemed to be affect immunogenicity, as the study showed that increasing the amount of the vaccines from 15 to 45 and 135 micrograms seemed to induce higher rate of seroconversion. As we saw before with the COVID-19 vaccine, the effect of anti-CD20 monoclonal antibody in the last 6 months reduced the rate of seroconversion compared to control patients. And the recent meta-analysis published in 2022 showed that seroconversion after seasonal vaccines, influenza vaccines, seem to be abrogated for at least 6 months following anti-CD20 treatment. and may not reach the level of healthy control even after 12 months, with an estimated seroconversion rates of 3 to 43%. However, the seasonal flu vaccine are recommended as recombinant or inactivated vaccines in elderly patients and those under anti-CD20 treatment. An adjuvanted or high dose vaccine is suggested. Whenever possible, anti-CD20 therapy initiation should be delayed at least 2 weeks after vaccination, and in patients on active anti-CD20 treatment, for instance, during maintenance in follicular lymphoma, we should consider at least 4 weeks before the next scheduled therapy. Now I speak about varicella zoster virus. That is a DNA virus belonging to herpes viridae family after the primary infection, varicella or chickenpox. This virus establishes latency in sensory neural ganglia, and after the waning of cellular immunity may reactivate, especially in elderly or immunocompromised patients. These non-Hodgkin lymphoma patients are at high risk of vis-a-vis reactivation due to disease and treatment-related immunosuppression, and these reactivations can occur up to 50 months after the initiation of immunochemotherapy, especially in patients treated with bendamustine rituximab BR. Other risk factors are age above 60 years, high cumulative dose of corticosteroids, and advanced lines of therapy. An antiviral prophylaxis with acyclovir or valacyclovir is recommended, especially in B-cell non-Hodgkin lymphoma patient with treatment-related risk factor for at least 1 year. At least the duration may be individualized according to treatment-related risk factors. There are currently 2 varicella zoster virus vaccine available. One is Zostavax, that is a live attenuated vaccine that is contraindicated in immunosuppressive patients, such as non-Hodgkin lymphoma patients. And the other is Shingrix, that is an adjuvanted recombinant subunit zoster vaccine. The phase 3 ZO50 trial was a randomized trial that showed a clear reduction in the risk of vis-a-vis reactivation at 3 years in more than 50,000 subjects. Recently, this vaccine was approved in Europe for the prevention of varicella zoster virus and postherpetic neuralgia in subjects aged 50 years or above, and those aged at least 18 years who are at increased risk of reactivation, the immunosuppressed patients. And dedicated studies evaluated the safety, the immunogenicity, and efficacy of Shingrix in hematological malignancy patients. This is the most important trial evaluating this vaccine in adult patients with hematological malignancies. It is a large randomized study in more than 500 of patients evaluating Shingrix versus placebo. The study included 40 cases with non-Hodgkin lymphoma treated in the experimental arm and 39 in the placebo arm. Patients received 2 doses of Shingrix 1 to 2 months apart during or at the end of treatment. Seroconversion was defined as at least a 4-fold increase in vis-a-vis anti-glycoprotein E IgG. A subset of patients underwent evaluation of cellular immunity. Around 30% received antiviral prophylaxis. Safety and mortality were comparable in the 2 arms, and overall the study showed a 87.2% risk reduction in the incidence of vis-a-vis reactivation, with only 2 cases of herpes zoster events in the experimental trial, and these 2 patients received rituximab in the last 6 months. A post-hoc analysis evaluated humoral immunity in B-cell non-Hodgkin lymphoma patients after Shingrix, and this analysis showed that patients with non-Hodgkin lymphoma exhibited a lower antibody response compared to other hematological malignancies at all time points, 1 month after dose 1, 1 month after dose 2, and 12 months after dose 2, likely due to anti-CD20 treatments, although details were not furnished. Another post-hoc analysis evaluated cellular immunity in non-Hodgkin lymphoma patients, and this analysis showed that the percentage of non-Hodgkin lymphoma patients with cellular immunity responses was comparable with the remaining patients, differently from humoral immunity, and glycoprotein E CD4 positive T cell responses remained above the pre-vaccine levels even after 12 months from the second dose. This vaccine was evaluated also in patients under BTK inhibitors. This is one study in CLL showing that patients under BTK develop inferior rate of seroconversion after Shingrix, about 30%, 40% in antibody response compared to 76% in treatment-naive patients, and 40% in cellular response compared to 70% of treatment-naive patients. So these are the recommendations. This vaccine is recommended in patients with lymphoma with 2 doses of Shingrix. The supportive data are moderate, and the timing, according to timing in relation to anti-CD20 treatment were the same. However, the recent ASCO guidelines suggest the possibility to administer at least the second dose after 4 weeks from the most recent anti-CD20 administration. So now I'll talk about pneumococcal vaccination. In patients with non-Hodgkin lymphoma, there is still an high incidence of invasive diseases by pneumococcus that are frequently severe and may lead to high rate of mortality. There are 2 types of vaccines against pneumococcus: the conjugate vaccines, PCV15 or PCV20, and the 23-valent polysaccharide vaccine, PPSV23. Conjugate vaccines are composed by protein carrier combined with capsular polysaccharides, while polysaccharide vaccines are composed by capsular polysaccharide antigens only. Conjugate vaccine induced T-cell dependent immune response will develop on immune memory, generating long-lasting responses, while polysaccharide vaccine induce only a T-cell independent antibody response. This vaccine covers a greater number of serotypes, however, is less effective and the immunity is less lasting, especially in older or immunocompromised patients. There are, however, very few real-world data in patients with B-cell non-Hodgkin lymphoma. There are some data in patients with CLL. This is an Italian study showing that only 8% of patients with CLL developed immune responses, and this study suggested to investigate other strategies, such as the so-called sequential strategies of PCV followed by PPSV23. This strategy was evaluated in a recently published study by Dutch colleagues evaluating 143 CLL patients. Overall, 10.5% of patients developed serologic response, evaluated as a 4-fold antibody increase against 70% of the measured serotypes, and only 3% of treated patients developed antibody response. So there are very few data, so the strength of the recommendation is weak. However, in this setting, it is recommended 1 dose of PCV15 and 1 dose of PPSV23 at 8 weeks interval, or a single dose of the novel PCV20 with the same timing in relation to anti-CD20 treatment, as shown before. Few words about Haemophilus influenza B vaccines. after the introduction in the 90s of the universal HIV vaccination in US and Europe, invasive infection by this bacterium have become uncommon. However, there are still reports of life-threatening infections such as pneumonia, pleuritis, skin and soft tissue infections, arthritis, meningitis, especially immunocompromised and cancer patients. This vaccination is mandatory for any immunized subject who is undergoing a splenectomy, such as, for instance, patient with splenic marginal zone lymphoma, or any. And this vaccine was shown to induce a good rate of seroprotection in patients with lymphoma. So a single dose is suggested in this patient population. In patients who underwent stem cell transplantation, a different schedule of 3 doses 4 weeks apart is suggested. Meningococcal vaccination may be important, especially in a patient with risk factor for invasive meningococcal and fatal meningitis, such as patient with congenital or acquired immunodeficiency, with anatomic or functional hypo or asplenia. So this vaccination is recommended in sickle cell patient, disease patient, HIV infection, and those receiving eculizumab. However, it was reported an increased mortality risk from 2 to 40-fold also in patients with lymphoma. So vaccination is suggested also in this population, including both tetravalent conjugated and monovalent vaccines with the same timing as we saw before for other vaccines. There are few data about tetanus, diphtheria, and polio vaccines after treatments in patients with hematological malignancies. We know that the immunity of childhood vaccinations such as tetanus, diphtheria are lost after pediatric acute lymphocytic leukemia treatments such as allogeneic stem cell transplantation. This patient should be revaccinated after the transplant. However, there are scarce data about adult patients with hematological malignancies undergoing B-cell depletion treatments. This is the only study reported in the literature evaluating 104 patients, including 80 patients with lymphoma, and 48 were treated with rituximab. This study evaluated antibody levels by ELISA of tetanus, diphtheria, and poliovirus serotypes 1 and 3. These are the results for tetanus. The non-immune patients were higher after therapy with an inverse correlation with age, and the post-treatment antibody levels significantly decreased. The same figure was reported for diphtheria, while for the poliovirus there was no difference in the percentage of non-immune patients pre and post-treatment. So these are the recommendation. The vaccine product, tetanus, diphtheria, acellular pertussis vaccine, TDAP or TD inactivated vaccine, should be checked in patient, especially patients should be asked about the last booster dose of this vaccine, and those who did not receive a dose in the last 10 years must be immunized. Should be also do a special attention on serological testing and revaccination after at least 6 months from the last administration of anti-CD20 monoclonal antibodies, as probably the protective rates of antibody level will decrease or disappear in this patient. Regarding hepatitis B virus, universal vaccination of child is a common practice now in many countries with a recombinant HPV vaccine that yield a seroconversion in more than 90% of cases. However, the majority of patients with lymphoma are not still vaccinated, due to the high median age of onset of lymphoma. HPV screening is mandatory for all non-Hodgkin lymphoma patients, especially if treated with anti-CD20 monoclonal antibodies, and antiviral prophylaxis in HPS antigen or those with anticore and antibody and HPV DNA positivity is mandatory. There is some room for vaccination in patients unvaccinated on those with undetectable anti-HPS antibodies when an immediate active treatment is not predicted, such as an indolent lymphoma patient in watch and wait, and this vaccine is recommended in patients with additional risk factor, such as the patient with a sexual partner with HPV positive, or at high risk of percutaneous exposure, or patient traveling to countries with high HPV infection prevalence. However, there are very few data about HPV vaccine efficacy in non-Hodgkin lymphoma patients. A recent study shows a substantial rate of seroprotection, 64%, in elderly patients undergoing HPV vaccination after more than 12 months from rituximab completion. HIV inactivated vaccine, 2 doses 6 months apart, is recommended in non-immune subjects living on traveling to endemic areas and immunocompromised patients are at high risk of developing severe HIV disease. However, there are very few data about HIV vaccine efficacy in the specific setting of lymphoma patients, and similar recommendation may be done from similarly to other types of vaccine, and patient at high risk in case of short-term exposition and alternative immune prophylaxis with protective intravenous immunoglobulins may be instituted. So these are the recommendations for HPV and HIV vaccines. Finally, the respiratory syncytial virus (RSV) vaccination is RSV is an emergent respiratory pathogen, especially among older adults and immunocompromised patients. Recently, 2 vaccine products were demonstrated to be effective and safe against this pathogen in older adults aged 60 years or more, and these are the 2 products approved. The CDC recommended that adult patients aged 60 years or older, including immunocompromised or those with hematological malignancies, should receive a single dose of RSV vaccine after a discussion with their healthcare provider, the so-called shared clinical decision making. So we proposed that this novel vaccine should be recommended in adult patients 60 years or older following a discussion with their healthcare provider, as this is an emergent pathogen, especially after COVID-19 pandemic in our country. So this is a synoptic summary of this recommendation. I don't go into details as we spoke about a few minutes ago, and I'll show you that in March 2024, a very important guideline was published by ASCO, the guidelines about vaccination for adult patients undergoing cancer treatment. So in the oncology setting, including hematological malignancies and lymphoma patients. And these are a summary of the recommendation. This guideline stresses about also vaccine for close contacts and caregiver, and are very relevant guidelines, and I read carefully and we are substantially in accordance with we proposed in our paper. few words about CAR T-cell treated patient. CAR T-cell induce very long immunosuppression due to immunoreduction of immunoglobulins. This guidelines suggest to evaluate check antibody titers after 6 months and then vaccinate after 6 months. The ASCO guidelines suggest to vaccinate patients for influenza and COVID at least 2 weeks before lymphodepleting treatment, or revaccinate patient after 3 months after CAR T-cell infusion. And these are an example of a calendar of vaccination. However, as I said before, there are few data. However, ASCO guidelines suggest to start vaccination for COVID-19 and influenza after 3 months, and the other inactivated vaccines after 6 months from CAR T-cell infusion. Finally, I will talk you briefly about our prospective study named FILFOL-VAX22 that we launched in Italy, evaluating prospectively the immunity to COVID-19 and other vaccines in patients with follicular lymphoma undergoing frontline induction immunochemotherapy and anti-CD20 maintenance. This is a prospective observational biological study about vaccine-induced immunity for COVID-19, varicella zoster virus, and diphtheria and tetanus. Patient, after signature informed consent, will undergo to sampling at baseline and other free time points during induction, immunochemotherapy, and maintenance. All the sample will be shipped to a central laboratory for the analysis of cellular and humoral immunity for COVID-19 and varicella zoster virus, and for humoral immunity evaluation from diphtheria and tetanus. It's a very complex scheme of FOL-19. That is our national study in follicular lymphoma patients. Basically, in the standard arm patient, we undergo standard induction with rituximab or obinutuzumab based chemotherapy with 6 or 8 cycles of immunochemotherapy, while in the experimental arm are the patient in complete response at the interim restaging after 4 cycles. Patient in CR will not receive 2 cycles of chemotherapy. So 2 cycles of chemotherapy were omitted while continuing monoclonal antibody. So at these time points, we will collect samples from patients to evaluate vaccine immunity. The primary endpoint was the evaluation of cellular immunity against SARS-CoV-2, and there are other secondary endpoints. There are an exploratory objective for the evaluation of T-cell immune status, as there is a correlation with T-cell exhaustion and T-cell immunosenescence with the activity and of vaccines. These are the selection criteria, very simple. Patients should have been vaccinated with at least 3 doses and should be enrolled in the FOL-19 study. There are the details. The patient cellular immunity will be evaluated by ELISpot assay for SARS-CoV-2 and varicella zoster virus, and by ELISA for the humoral immunity, and by flow cytometry with an extended panel of flow cytometry for multiple T-cell immunological parameters. Data about timing and type of vaccines will be collected, as well as the number of infection and the timing of infection. We planned to enroll 56 patients across 15 field centers with the duration of the study of 3 years. So this is my last slide. I thank you for your attention, and this is my contacts, and I'll be happy to take your question. Thank you very much.
Thank you, Dr. Michael Mully, for that wonderful view on vaccinations. You totally covered entire thing. That was fantastic, sir. Thank you so much, sir. And I now request.
Okay.
And I now
So
request.
just a moment.
Yeah. So if you can unshare your screen, sir. Yeah. You
Okay.
can unshare. Yeah. So we can visualize each other, sir. I request all our discussants to please put the raise hand sign so that we can start our question answer session with Dr. Michael Mully. So in the meanwhile, as the discussions put the raise hand signs, I will read out some of the questions from the audience. So Dr. Ghanshyam Biswas has a question. Which one plays the most important role in vaccination effectiveness? Type of lymphoma, whether patient comorbidities, or the type of treatment?
Yes. I think probably type of treatment. Basically, all non-Hodgkin lymphoma will respond similarly to every type of vaccines, but timing and type of treatment will affect the response. Now, for instance, I did not speak about the specific monoclonal antibody that are CD20, CD3 monoclonal antibody that abrogates vaccine response in high percentage of cases, and so many clinical trials were affected by the COVID pandemic, and there were a lot of death related to COVID-19. So probably the most relevant factor is the type of treatment more than the type of lymphoma.
Thank you, sir. Another question he has is vaccination schedule different for HIV-related lymphomas and transplant-related lymphomas?
Sorry, can you repeat?
Is vaccination schedule different for HIV and transplant-related lymphomas?
No, all the vaccines should be the same. Obviously, also only activated vaccine, also unit vaccines should be instituted, and non-live vaccines. However, also HIV patients should receive the same type of vaccines. There are and it's very important for HIV patients to be vaccinated.
Thank you, sir. And the question he has is, how common is tuberculosis reactivation in your practice in lymphoma patients?
Sorry?
How common is to have tuberculosis reactivation in your practice in lymphoma patients? Tuberculosis.
Reactivation of what?
Tuberculosis, TB. Tuberculosis.
Tuberculosis.
Yes.
No.
How
Yes,
common is tuberculosis reactivation in lymphoma patients on therapy?
Tuberculosis, yes, we have many cases. So we check at the start of the treatments for quantiferon, and patient with positive quantiferon should be evaluated with other exams, and so there is the need for prophylaxis with isoniazid or more intensive anti-tuberculosis prophylaxis, maybe especially for those treated with anti-CD20 treatment, a real concern.
Okay, sir. Thank you so much, sir. Another question is from Dr. Ghanshyam Biswas. Can we give HPV vaccine to an eligible young girl who has been diagnosed with lymphoma?
Yes, also ASCO guidelines and ECU7 guidelines suggest HPV vaccine in young girls. Yes, there is no contraindication, and also novel guidelines suggest also to address this issue in young patients. Yes, because there are subunit vaccines, so there are no concerns about safety.
Thank you, sir. Another question from Dr. Aruna Pujari. has a routine, is it routine to, you should check for cellular as well as humoral immunity response, which should be measured in this set of patients against specific disease?
Yes, this is a great question. In the most during the pandemic, where there was very high rates of infection, probably the testing of humoral immunity was frequently adopted and should be were very useful. Probably depending of the epidemiology of COVID-19. However, also nowadays infection are increasing also in Italy, so probably should be useful to evaluate at least humoral immunity if available, also cellular immunity for COVID-19. Maybe the evaluation also of varicella zoster virus antibody should be useful, especially to evaluate the efficacy of Shingrix vaccines, and we probably with this will help us to understand if it is safe to not push with antiviral prophylaxis, for instance, for patients treated with bendamustine, rituximab, or BTK inhibitors. So probably these are two tests that should be evaluated, at least for patients with high risk of infection or high risk treated with high risk therapies. For instance, CAR T cells or bispecific antibodies or immunochemotherapy.
Thank you, sir. Another question from Dr. Umang. While it's an established fact that live vaccines are generally contraindicated in immunocompromised patients, there are some groups who have tried using varicella and MMR vaccines in liver transplant recipients and has found to be very safe. Any data on lymphoma patients that you may tell us about?
Yes, this is a very, very great question. Probably there are very few data. Probably there is a excessive concern, the one about live vaccines. As you told, there are experiences with of safe use of MMR vaccines, also in the transplant setting. Current guidelines suggest to await at least 12 months after transplant or after CAR T cells, but patient with a high risk, also these vaccines should be maybe used safely. However, there are very few data. We don't have any data. We are not planning to evaluate this vaccine, but probably next study will address this issue.
Thank you, sir. Dr. Satrupa Mahapatra, your question. You're muted, Dr. Satrupa. Please unmute yourself.
Yeah, hello, Dr. Murli. It was a very comprehensive talk. You've almost covered everything. I wanted to know regarding the timing of vaccination patients who are on continuous therapy like BTKI inhibitors in CLL. So how do you time your vaccination in such patients?
Yes, this is a great question. As you BTK treatment is a continuous treatment, so patients that are already on BTK cannot or stop or interrupt treatment safely. There are some studies showing that, for instance, 2 windows interruption of BTK before immunization may improve the response rate. However, this is our data in Waldenstrom macroglobulinemia, where, however, the interruption is not so critical. However, the current guidelines did not suggest this strategy. Probably in this setting, should be used periodic boosters to improve this the response to vaccines. So I don't have any suggestion about interruption of withdrawal of BTK treatments, but to follow strict calendar of booster administration yearly, at least in this setting of patients.
Thank you. I just have another question, if I can go ahead.
Go ahead.
So where in cases of these high-grade lymphomas where you really can't wait to initiate your treatment, so what is your vaccination strategy then in very high-grade lymphomas where we don't have that 2 weeks of waiting time?
The time, yes, it's another very interesting question, very problem that occur very frequently. Yes, obviously we have to start to treat the patients. Probably yes, at the beginning when we see for the first time this patient, we have to start as early as we can the first immunization, and then we'll start the treatment, the best treatment for the patient, and we can administer the other, the less important immunization in the time interval between treatments. So we can see better, we can do better of this, but it would be important to start the first immunization at least 1 week before, so we can arrange the time, but we can do the best also on this.
Tough group to treat, yeah, to vaccinate, yeah.
Okay.
Thank you so much.
Thank you. So on the same note, if the patient has been started on R-CHOP chemotherapy at once, because we have got no time left for example, in case of multiple myeloma, when the first dose of bortezomib has to be given, and before the next cycle start, can we wait? Can we give between the 2 cycles these vaccinations?
So can you repeat?
So we have got no time for high-grade lymphomas.
Yes.
It's very much urgent, as well as even for multiple myeloma, where the treatment is very much urgent, because we need to start the patient on bortezomib. Then you got lenalidomide, dexamethasone immediately in case of multiple myeloma, as well as in case of high-grade lymphomas, the monoclonal antibodies has to be given at once on urgent basis. So we have got no time left for the vaccination. So after the first cycle is over and before the second cycle start, can we give that vaccination?
Yes, it's a good question. Yes, we can try to, if there is no time to do vaccination before the start of the first cycle, can try to vaccinate patients as soon as possible. However, one strategy could be to defer the monoclonal antibody, so start only CHOP chemotherapy, for instance, and immunize patient, and then start the first dose of rituximab 2 weeks after. So we can start with chemotherapy that impair less the humoral immunity development, and then start anti-CD20 treatment 2 weeks after, because probably the urgence is to start chemotherapy in lymphoma patient, and the monoclonal antibody should be maybe add thereafter.
Thank you, sir. Dr. Satrapi, you have another question? Okay, a similar question was asked by Dr. Krishnadar Kanam for the patients with high-grade lymphomas. How do you manage with vaccinations? Another question is from Dr. Tribikram Panda. Should we add Shingrix vaccine to those patients who have already received varicella vaccine in the past? And what's the role of added benefit with adding Shingrix vaccine now, if patient has already received varicella vaccine in the past?
So for varicella vaccine, yes, the novel vaccine that has been approved is very effective, and also in this 2-dose vaccine. So probably in this setting, it is important, it's crucial to start the first vaccine before the start of chemotherapy, and the second dose after 1 month from the last chemoimmunotherapy as suggested by ASCO guidelines should be sufficient to develop a protective immunity. So this is a very useful tool that we have nowadays compared to the past, where there were no available vaccines, and so the zoster reactivation was very frequent despite of antiviral prophylaxis. Or in the past we used a very long time of antiviral prophylaxis, and probably with this vaccine we can spare long times of antiviral prophylaxis with acyclovir or valacyclovir.
Thank you, sir. Another similar question from Dr. Yimon Tent. What is your usual recommendation for those patients who are using just chemotherapy, vaccination time for those patients who are just receiving chemotherapy, as well as those patients who are going to receive anti-CD20 based chemotherapy? Usual vaccination time.
Yes, I said before, usually if we start 2 weeks before the vaccine, the start of chemoimmunotherapy, or for those under treatment, we have to await possibly 6 months, at least 6 months, and better would be 12 months. However, in some cases, for instance, for seasonal influenza virus, it is not possible because it is a seasonal infection, so we can adapt this timing as I said before. For instance, 1 month before and 1 month after the last administration, if it is possible. So we can arrange the timing according to the treatments with the aim to try to vaccinate in the best timing from the previous and from the next scheduled treatment. However, we suggest to vaccinate this patient also if we predict that the antibody level should not be very satisfactory, because we don't know very much about cellular immunity. We demonstrated with COVID that also under active anti-CD20 treatment, cellular immunity increased. So we don't know for other vaccines, but probably the effect is the same for influenza, and especially for zoster. The importance of cellular immunity is very high. So it is not possible to arrange the best time interval. We suggest to vaccinate, however, the patient the same. So, okay.
Thank you, sir. Any discussion want to ask any other question to Dr. Michael Murley? Well, so, sir, there are no more raising signs, and I have finished all the questions from the audience. Well,
Okay.
Thank you so much for that fantastic and lovely lecture.
Thank you very much.
It was a very good learning from you, and wonderful. You solved so many doubts of us and answered almost all our questions and all our doubts. Thank you so much for being with us.
Thank you so much.
Thanks
if
a
you
lot.
come in Italy, I will be happy to host you and to meet you.
Sure, sir. Thank you so much. Thanks
Thank
a
you.
lot.
Bye.
Bye. Have a nice day.
Bye.